Hello, my name is Abdulraheem Yacoub. I'm an associate professor at the University of Kansas, and it's my pleasure to discuss the advances of CML in 2021. I'm going to start with a case of Mr. J. He was 42 in 1999 when he presented with chronic CML. In the dark ages of CML at the time, there were no therapies, and he received therapy with hydroxyurea and supportive care. He was fortunate enough to enroll in the IRIS clinical trial, which is the famous trial that randomized imatinib against specific supportive care at the time, which was interferon plus cytarabine. And needless to say, the study was positive and the patient did great and continued on imatinib long term. By 2007, he was 50 and he had side effects to imatinib and cardiomyopathy. By then, he had lived enough to see the second generations of tyrosine kinase inhibitor, dasatinib, for which he received therapy and achieved a deep molecular response. 10 years later, he continues to be in deep molecular response, and he was offered to discontinue therapy. 3 years later, he remains off therapy in deep molecular remission. So fortunately for him, he will enjoy his life cancer-free and treatment-free for now. So what is CML? CML is a myeloproliferative neoplasm that is defined by the rearrangements of BCR and ABL, most commonly due to a chromosomal translocation. Famous for the Philadelphia chromosome, named after the city that defined this disease. The BCR-ABL rearrangements result in a protein product that does not exist in nature, the BCR-ABL, which is responsible for all the disease manifestations, including leukocytosis, thrombocytosis, the heavy burden of constitutional symptoms, splenomegaly, as well as the occasional accelerated and blastic phase of the disease. Fortunately, we've made big strides in the management of CML. Patients who were diagnosed before the TKI era had a life expectancy of 5 years and poor outcomes. Fortunately, now patients diagnosed are fortunate to expect a normal life expectancy that is not different from their age peers. This significant improvement is attributable to the discovery and approvals of all the modern tyrosine kinase inhibitors. We've also made strides with our prognostic models. The so-called score and the more recent European score are clinical determinant scores that can classify patients into lower risk versus higher risk. These scores have been able to predict overall survival, risk of transformation, response rates to tyrosine kinase inhibitors. They also are valid for the prediction of response of major molecular responses and deep responses. They are also able to predict the eligibility for treatment-free remission and as far as relapses after end of therapy. So their prognostic value remains stable even after so many years of therapy. There are a few additional prognostic models that are evolving, and some of them are ready for prime time, including the ACA. Treatment goals for CML is to achieve a clinical, cytogenetic, and molecular remissions that are sustained. Hopefully achieve that without disease-related symptoms or complications and without treatment-related toxicity. Also to mitigate the cardiovascular risk associated with the disease and the treatment. And in some patients, the appropriate patients, is to plan them for treatment-free remission downstream. CML is a model disease where we were able to define treatment goals with treatment milestones that actually correlate with clinical outcomes and has resulted in very regimented milestone assessment that has incorporated in our standard of care for the last 10 years or so. This has been standardized and universally accepted as the goals of care in these patients. This is the NCCN Guidelines for treatment of CML. For newly diagnosed patients who happen to be low risk, therapy with imatinib might be appropriate. However, second-generation tyrosine kinase inhibitors are also an option in select patients. In patients with higher risk disease, we prefer to start a second-generation tyrosine kinase inhibitor in those patients. That being said, the randomized clinical trials have not shown superiority in overall survival of any of the second generation tyrosine kinase inhibitors. So that was not the only driving reason behind this recommendation. However, almost consistently, all the second generation tyrosine kinase inhibitors have shown a faster and deeper response molecularly compared to imatinib, which is the original standard of care. This slide represents the responses in the decisive clinical trial for dasatinib versus imatinib. Similarly, in the INSTIND study with nilotinib versus imatinib, and the more recent before study for the bosutinib against imatinib. So, although none of those studies resulted in overall survival advantage, but they consistently showed deeper and faster molecular responses. Comparing these agents to each other was recently done and presented in ASH, showing absolutely no superiority of one agent over the other in the first line setting. So that is not the rationale for choosing one of those agents. It's mostly based on adverse event profile. What do we do beyond first line therapy? Unfortunately, the common reason for treatment failure remains compliance, so that needs to be assessed. We also need to evaluate the disease for clonal evolution in the bone marrow or tyrosine kinase domain mutations. And accordingly, the choice of a second or third generation tyrosine kinase based on patient's factors, based on side effect profile, and patient's comorbidities. Fortunately, we have a new class of drugs to talk about this year. So presented in ASH of this year is the results of the ASSEMBLE clinical trial. This study compared a novel agent, a first-in-class asciminib, to bosutinib in the third line setting. So bosutinib and all other tyrosine kinase inhibitors, as you can see on the graph, they are reversible inhibitors of the tyrosine kinase domain, while asciminib binds ABL at a different domain and results in a different activity level and side effect profile that is not similar to tyrosine kinase inhibitors. And in this particular study, asciminib was superior to bosutinib with higher response rates and earlier responses, which was very pleasing to all parties involved and all the patients involved in the study. In addition, asciminib actually had fewer side effect profiles and none of the TKI classic side effects, including musculoskeletal pains and fluid retention, which is a great achievement for our patients and a great addition to our armamentarium. So, treatment-free remission. My patient's story is not unique. This is here to stay. So we've learned over the years that patients have variable and heterogeneous response patterns to tyrosine kinase inhibitors. Some patients are primary refractory, some patients are slow responders, but some patients are rapid responders who achieve a rapid, deep, and sustained response. So sustained that they might have the opportunity to discontinue therapy and remain in remission, which is the definition of treatment-free remission. We estimate that 1/4 to 1/3 of all patients will be candidates for this at diagnosis. There's been a robust body of evidence and many prospective cohorts showing feasibility of this approach and success of this approach. There are now NCCN guidelines that guide us towards this process. The NCCN guidelines are somewhat loose, and many of the prospective studies had more stringent criteria for discontinuation, but this at least provides a platform for us to guide us through this process and how to observe patients after discontinuation. Treatment-free remission is dependent on many factors, that some of them are modifiable. So there are CML risk factors that predict that, including high-risk disease, genomic events. There's also the choice of therapy and compliance to therapy, in addition to cancer dynamics of the response in each individual patient. For example, patients with high-risk disease continue to fare less favorably compared to patients with low-risk disease with any agent. However, they actually do better on second-generation tyrosine kinase, and they have more probability of discontinuation if they received a second-generation tyrosine kinase inhibitor, which kind of reinforces our choices based at diagnosis by choosing a second generation for first-line therapy. So in conclusion, our knowledge and insights of the pathogenesis and outcome of CML is evolving. Most patients with CML should expect a life expectancy that is not different from their peers. And a subgroup of them should expect a treatment-free remission after many years of therapy. Better therapy is needed for patients with high-risk disease and for patients who failed tyrosine kinase therapy, and we're glad that we're making strides in that. Allogeneic stem cell transplantation, I did not discuss that today. However, it remains a curative option for patients who fail medical therapy. Thank you all, and I'm happy to take any questions.